Pulmonary embolism is a significant health problem in the United States. It's the #3 cause of cardiovascular death after stroke and heart attack. Not all pulmonary emboli are the same. They are usually categorized into minor or low risk, submassive or intermediate risk, and then massive, which is high risk. It's that middle category, the submassive PE, that is still very dangerous. The mortality rate is about 20% at 90 days, and the in-hospital mortality rate ranges somewhere between 5 and 15%, and it's underdiagnosed. And that is where a lot of new data has come in just the last few years that gives us a new opportunity to diagnose and to treat those patients. Most patients get diagnosed with PE by getting a CT scan of the chest with contrast, what we call a CT angiogram, that's specific to look at the pulmonary arteries. And so what we need to do to get these patients out of that high risk category for morbidity and mortality is we have to unload the pressure from the right heart. We have to melt the clot in the pulmonary artery. The faster we do that, the faster the right heart returns to normal. The other benefit is the sooner we can get the heart back to functioning like normal, the less chance there is for long-term events like chronic right heart dysfunction and chronic pulmonary arterial hypertension. When there is clot in the pulmonary artery, the TPA has a harder time circulating to it because that part of the lung, when you have a ventilation and perfusion mismatch, you end up getting decreased blood flow to the clot, and so you get more of a systemic effect. And in most of the trials that have compared heparin versus heparin with just TPA in an IV, the elephant in the room has always been this 2 to 3% risk of bleeding inside the brain, an intracranial hemorrhage, which causes a debilitating stroke at the best or death at the worst. And that's always been what has kept us from treating more patients with the clot-busting medicine, TPA. The ECOS device is a novel device that actually has a thin thread with high-intensity ultrasound emitters along the course of the catheter. And what those ultrasound emitters do is they call this process ultrasound accelerated thrombolysis. The high-frequency sound waves actually cause disaggregation of the fibrin and the thrombin, opening more binding sites so that the thrombolytic medicine, the TPA, can bind more and you have less systemic effect, more effect directly in the thrombus. Furthermore, if you have the catheter actually embedded in the thrombus, just like if you have a leaf floating on a pond and you throw a rock next to it, the ripples from the rock are going to carry the leaf out with the ripples. You get a small amount of acoustic streaming where the sound waves actually carry the TPA further into the clot. And so the bottom line is with the least amount of thrombolytic, the least amount of TPA, and the least amount of time, you get the maximal effect on the clot and the minimal effect on the body. Once these patients are better, which is very quickly, usually overnight, the things that we've seen happen to folks overnight are their breathing improves, they feel less like there's an elephant sitting on their chest, their blood pressure comes up, their heart rate goes down, and within 12 or 24 hours when we take the catheters out, we remeasure the pulmonary artery pressure, and we're seeing statistically significant decreases in the mean pulmonary artery pressure in just that fast of a time frame. The vascular and interventional radiologists of Greensboro Radiology partnered with Pulmonary and Critical Care of LeBauer Healthcare and Cone, and we created a Code PE team to serve all of the patients in the Cone Health system. And we are also have joined a multi-state registry in order to put our results and our data into that pool, because this is new frontier, this is very cutting edge, and we want to be part of the groups that are collecting the data so that we can fine-tune this treatment over time and give patients the best care possible.
Leading radiology excellence through personalized and compassionate care. Greensboro Radiology. For more information, call 336-274-6682 or visit greensbororadiology.com.